supraspinatus. Now the supraspinatus, like I mentioned earlier, the best way to see it is we have to put them into extension, okay? So we're gonna put this patient in what's called the crass position, or in this view, actually, nope, flip around the other way, the semi-crass position. So you put your hand on your hip, and I'm having you scoot forward in your chair so you're not touching the back. Good. And then put this elbow into a little bit of extension. So we're really putting the shoulder in extension, exposing the tendon from underneath the acromion. All right. Now in this view, we're going to start in long axis. So we're going to look. So how do I know it's supraspinatus? Well, I know where the biceps is. Okay, and we know that the supraspinatus is lateral and posterior to the bicep. We're seeing bicep fibers here. I'm going to move slightly lateral to it. And the first structure you move into, this bird's beak, is the supraspinatus. Okay, so I'm going to go over a couple important landmarks. Okay, the footprint of the tendon is about 12 to 16 millimeters. Okay, so if I'm correct, if I'm in that range, the articular surface of the humerus starts to drop off right here, and it forms the ball and moves into the humeral shaft off to the left. Okay, the footprint is from here to here, so I'm about right. It's 11 or 1.14 centimeters, 11.5 millimeters. Okay, so we ballpark that just about right, and then from here down is your articular margin. So just so you understand bony landmarks, you understand the anatomy. We're not just anatomy generalists. You have to be able to master these positions. Okay, so keeping our patient in this position here. Again, let's find that view. See how this hooks in? This is this hump right here. This helps us separate kind of the footprint of the insertion versus the articular margin of the humerus. And our tendon is basically from here to here. Okay, subacromial peribursal fat layer is basically from here to here, and then over the top is our deltoid muscle subcutaneous layer on the very top. Okay, now some nice things you can do with the ultrasound that separates it from other imaging modalities is the dynamic aspect. I got you, let me just take your elbow. Okay, so what we're looking, I'm just wagging this patient's elbow through kind of an assisted range of motion into extension. Okay, what am I doing in extension? Well, I'm stressing the footprint of the rotator cuff. Okay, if there's oftentimes with big retracted tears, what you see when you put the patient into extension, you see some tendon retraction. You'll see the tendon move one way, the bone move the other. As you see what we call this paradox of movement between the two, the tendon-bone relationship, okay? But in a healthy shoulder, you'll see them both move at the same rate, which is what we see here, okay? So whatever you look in one view, you look in another. So I'm going to turn it into short axis in this view, and I'm going to come up on what we call the rotator cuff interval. Okay, so in short axis, humerus, greater tuberosity. We have the biceps long head tendon right here. This hypoechoic appearance just lateral to the biceps is there's some capsule and some of the glenohumeral ligament in this picture that gives it that appearance. This is not pathology. And this hypoechoic line, kind of adjacent to the humerus, signifies that I'm really probably at the articular margin in this view, meaning the reason why is because the articular surface of the hyaline cartilage gives a hypoechoic appearance because it's high in water content, and above it, this hyperechoic layer is the tendon, and then the bursa is this bright fascial line superficial to the tendon. Okay, so back to that. Let's get back to that view right here. Okay, so we have bicep, humerus, articular cartilage, tendon, bursa, and the deltoid. This is darker muscle. Remember, muscle is high in water content. It's going to be darker than the tendon, so you get a nice contrast between the two. All right. Now, from here, you like to scan. Okay, so scan just And anterior, scan posterior. So see how small I'm moving? We're talking millimeters. And I'm not just going back and forth. You're not going to see anything like that. You have to move in small little planes, constantly adjusting. So like I said, it's a motor skill. Once you understand the anatomy and you want to get good at ultrasound, you have to practice. It takes hours. And looking at a lot of healthy patients, okay, and understanding what normal is, because if you don't know what normal is, you don't know what abnormal is. So you have to be able to differentiate between the two. Okay, so I'm anteriorly in this view. That's essentially my rotator cuff evaluation, okay? Not a lot of you could do some dynamic studies in this picture where we're watching it move in short axis, see how the tendon is moving with the bone, moving with the biceps at that bicep pulley location. This is a nice healthy tissue, so we're not seeing anything atypical here. All right, have the patient relax.